Good morning, everyone. I'm Dr. Shankar Prinja. I'm a professor of health economics at PGI Chandigarh in India, and I'm also an executive director of the National Health Authority in the Government of India in Delhi. The paper that I'm going to present today is determining the price weights for a differential provider payment system under India's national publicly financed health insurance program. So just to give you a background, India launched a large publicly financed health insurance program in 2018, and this program is known as PMJAY, shortly called PMJ, and this uses a case-based payment system to reimburse the empaneled healthcare providers for a set of nearly 1,670 different procedures which fall under the category of medical or surgical procedures, which are listed under its health benefit package. And when I say that it's a case-based payment, it means that it's a lump sum payment, it's a bundled payment, which is inclusive of the pre-hospitalization, outpatient consultation, and the pre-diagnostic workup. It also includes any procedure that might be performed in terms of an operative care or in terms of any surgical procedure. It includes hospitalization expenditures, and also it includes post-discharge 15 days medication. So all of the total expenditure that is incurred by a hospital is paid as a bundled payment to the empaneled healthcare provider. And the payment is a uniform price that is set at the national level. However, in order to make the prices reflect more and to achieve reflect more in terms of the cost and to achieve certain social objectives, there is some degree of differentiation in the prices. For example, for all the hospitals that are located in the metro cities, there is a 10% higher price that is paid for each of the package. Similarly, in order to enhance the quality of care, all hospitals that are accredited under the Quality Certification Board in India, which is called as the NABH, there are different levels of incentives or price markups that are available to incentivize hospitals for a better quality of care. And finally, to achieve certain equity objectives, hospitals that are located in difficult areas, hard to reach districts, which are called as aspirational districts, there's a 10% higher markup. However, these additional markups or top-ups over the base price were determined based on a consultation and based on certain expert elicitation. So the purpose of this study was to determine an evidence-based methodology using cost data to develop price weights for the PMJAY scheme and to identify the right markups that should be provided for hospitals to reimburse them at different rates according to their supply side characteristics. And ultimately, the purpose was to ultimately use these regression weights in order to inform the reimbursement pricing under the National Insurance Program. So the study heavily relied on a large nationally representative health system costing study that was undertaken, which was called as the Cost of Health Services India study. And this study was funded by the Department of Health Research in India, and it was funded by the Government of India. And this study included collection of detailed cost data using a mix of bottom-up micro costing and top-down costing methods in a set of hospitals that included about 11 large public sector tertiary care hospitals, which were medical colleges. It included about 27 district hospitals, which were again the public sector, and it included 38 private hospitals as well. So the sample had a mix of both hospitals from the public sector and the private sector, and there was a methodology of selecting these hospitals from a range of different states. These hospitals were sampled from about 13 states in India, using a methodology which tried to stratify the hospitals according to the type of city in which they are located. The states were selected based on certain criteria in terms of their wealth status, in terms of the density of the health infrastructure, etc. And within each of these hospitals, all specialities were covered, which included a range of specialities starting from medicine, surgery, gynae, pediatrics, and super specialities like cardiology, cardiothoracic surgery, and likewise. So all specialities got covered, and overall the sample that was used for undertaking this regression-based cost function, which used the WHO WHO choice cost function approach, had a total of more than 200 specialities that were drawn from these hospitals. With the available data that we had, we ran a cost function, and the cost function was run separately for the set of surgical packages and separately for the medical packages. And the reason why the surgical and medical packages were analyzed in two different separate regression functions was because the determinants of cost of care and the initial descriptive analysis for heterogeneity showed that there were different levels to which the different input resources contributed to the overall cost. So as a result, these two were considered separately. So using an outcome which was per procedure cost or in a surgical package and per hospitalization cost in a medical package, a regression was run using a range of different factors that are listed here in the first column, which included factors like the number of inpatient beds. We adjusted for the level of capacity utilization by using bed occupancy rate as an indicator. We included the dummy for tertiary care, which means the hospitals were stratified in terms of whether these are providing tertiary level services or secondary level services, and whether it was a public or a private sector hospitals. And then we also had dummies for the location of the hospital in terms of the classification of the city where it was located. So traditionally in India, the cities are classified as tier 1, which is the cities that have the higher living costs, tier 2 which have lesser living cost, and tier 3 which are the ones that are which have the least living cost. So these were the factors that were included, and the model was also adjusted for some of the other variables such as the skill mix within the staff of the hospital, and there were two variables that were used for that: the doctor paramedics ratio and the ratio of the specialist paramedics. Similarly, the other factors that were included in the regression function were the volume of the hospital in terms of the patient footfall, and annual inpatient admissions was used as an indicator. Similarly, the state GSDP, or the gross state domestic product, which was a proxy for the level of income of the different states where the hospitals were located, was also used as a proxy, as an indicator. And finally, the state health index, which is an index that has been developed to rank the development status of a given state in terms of the different health parameters. So in a way, it is a kind of an indicator that tries to adjust for the demand side characteristics of a given state in terms of its health indicators. We log transformed because of the skewed nature of the cost data. Multicollinearity was considered, and the public and the private classification variable was not included in the final cost function due to multicollinearity. So ultimately, we wanted to derive the set of factors for the type of services that were being delivered. That means whether it was a tertiary care service or a secondary care service, whether and by the city, type of the city, whether it is a tier 1, tier 2, or a tier 3 city. While we adjusted for bed occupancy, this was only for the purpose of adjustment and not to use it as a price weight for payment, because we do not want to incentivize hospitals for not being efficient, or in other words, we do not want to disincentivize hospitals for being efficient. So those were the regression weights that we determined. And based on these regression weights, we ultimately determined what could be the potential price weights that could be used for surgical and medical packages. So what this means is that if the base rate is set, which is representative of a secondary care hospital that is located in a tier 3 city, then for any kind of a tertiary care package that is delivered by the hospital, it should be paid at a rate which is 33% higher. And similarly, as against the base rate, which is representative of a tier 3 city, the prices that should be set for hospitals providing services in tier 2 and tier 1 city should be set at 17% and 25% higher levels. And on a similar note, the price weights were determined for medical packages, where a 10% higher markup was for tertiary care medical packages and a 15% markup for both tier 2 and tier 1 cities relative to the tier 3 city. So overall, this study provides price weights for correcting for the supply side factors, which influence the costing structures of hospitals, and hence the prices should be differentially set according to the nature of these supply side factors. However, there is still scope for fine-tuning the price structure under the PMJY scheme, and the way forward involves trying to make the prices more sensitive to not just the hospital characteristics, but also the patient characteristics, which means for a given procedure or a package, patients with different levels of severity, which are being treated by hospitals should be paid differentially according to these. And in order to do that under the scheme, as a way forward, there is a pilot that has already been planned to be undertaken in 5 states to test the feasibility of introduction of a DRG-based payment system. And detailed patient-level cost data collection is being planned in order to be used for determining the cost weights that would ultimately be used for DRG-based payment systems. Thank you very much. I'd be happy to answer questions.